My name's Simon Jones. I'm a General Manager with a Mental Health and Learning Disability Trust in Bradford, West Yorkshire. What I do is I make sure that we deliver high quality mental health care to people aged between 16 and 65. My background is economics, and what I try and do is use information and feedback from users and carers to ensure that we do deliver services in a way that makes people's health much better and also spends the public money in a much more efficient way. Okay, so what is metrics? I think people think metrics is a very sophisticated term that then links to a very sophisticated set of actions. Metrics is actually the way we measure things. It's numbers, it's outputs. In the context of healthcare, what we use metrics for are two things. One, we use metrics to measure our performance, activity, how many people we see, how long they stay in our services for. We also use metrics to measure whether we make them better or not. You know, we measure through scales how they are when they come into our services, we treat them, and then we measure them when they leave our services. And all the metrics does is give us an indication of how we've gone from one point to another, and it measures it for us. Yeah, people will hear about measurements that are presented in terms of league tables and performance ratings, and that doesn't mean a great deal to the average user of healthcare services or the public. As an operational manager, what I want metrics to tell me is that we're actually spending our money efficiently and we are delivering the best possible service to the right people. So what I want to know isn't necessarily just how many of the people that we've seen, but I want to know what we've done with those people. Because what the public need is for me to focus in on using services in a way that works. Not that just tells a story about, well, you know, hypothetically, we've seen 1,000 patients this week, therefore we're a fantastic organisation. What I want to do is make sure that the patients that come into our services get the right service from the right people with the right training, so they walk away in a much better state of health than they did when they came in. I think in healthcare generally, out with mental health, it's actually quite a lot easier to measure progress that you make in somebody's treatment. We have a term in economics called utility. Utility is the quality bit that the user feels. Okay. Now we can measure that in a variety of ways. We can ask you questions before you receive a treatment and after you receive a treatment. And the trick is to match up the utility that you feel, so the improvement you feel as a user of healthcare services, with the resources that we've used to get you there. And you'll have heard of organisations like NICE, the National Institute for Clinical Excellence, and when they measure health technology or health treatment, they take that into account. They will take into account the quality that your health has improved by, or the utility, with the cost of actually delivering that intervention. Mental health is a little bit more difficult because it tends to be quite subjective in terms of how your health has actually moved on and improved. And we can use a range of outcome measures which are both clinically focused. In other words, the clinician, using some objective measurements, can say, well, at the start of the treatment you were X, at the end of the treatment you were Y. We can also use some measurements where we ask the patient or the user to actually tell us a story, tell us about how they've moved on from where they are, where they were, X months ago to where they are now. There's a combination of that measurement from the user about how they feel and our objective measurements of what we think has actually progressed with this patient, which allows us, I think, to judge whether or not we've actually done a good job or not. I think it's worth making the point, that in healthcare, we're probably the only industry in the world that doesn't actually fundamentally measure its product. We don't routinely measure whether we make people better. Back in the 70s and 80s, when things like internal markets were first thought of, and GP fund holding was an issue, which was really about GPs using money to actually drive forward buying interventions for their patients. You would have thought that measuring the outcomes of that would actually have helped improve the quality of the care. The problem then was that the way the system was set up was that there was no consistent measurements across the country, and one of the criticisms of GP fund holding back in the late 70s and early 80s was that actually depending on where you were in the country, depends on the quality of care that you've got, because there was no consistent measurement. We've moved forward now, and I think primary care, through their quality outcomes framework, are now much more consistently measuring progress across the nation. So it doesn't matter whether you live in Bradford or Bournemouth, there is a set of indicators that align your care to certain targets and certain aspirations. So that's progress. That's clearly good progress. I think the other thing that we've had over the last, 10 years is that the targets that have been set have been very central government-led targets. And the view has been that if we can set targets around activity and around response times, then that will drive up quality. And to a certain extent, it has. You know, you think about A&E targets, seeing patients within 4 hours. Nobody would argue that that's actually not a bad target. I think you come to a point, though, where you need to move on from that sort of activity and output-based targets as opposed to an outcome-based target. And, you know, the output targets are there about seeing people within 4 hours, seeing numbers of people, having numbers on caseloads, having response times for cancer, for cardiology, for A&E. We now need to have outcome-based targets. So actually, when a patient goes in to see a clinical practitioner, we are measuring how well we make them, how well we improve their healthcare state. And I think there is a view now that that's the way that we are going to move. And there is a suggestion that in the next round of targets, they will be much more outcome-based than output-based. And that's clearly, I think, a very healthy step. Yeah, the difference between an outcome and an output. An output for a health service, for a hospital, might be that you are required to see 100 patients within a 10-week time period. And if you see those 100 patients within a 10-week time period, you'll hit your target, you'll get a pat on the back. Very good. An outcome is that those 100 patients that you see will have walked into your hospital with a level of disability, and they will walk out of your hospital with a much lower level of disability. So the outcome is the improvement in health state. The output is the number of people or the number of units that you would see.